Started. Thanks to those that are able to join us. I am delighted to be able to introduce Dr. Jerry Zifodya for today's PCCSM Grand Rounds. Jerry comes to us through Tulane, which is where he started his medical career for medical school and also his MPH and Master's in Tropical Medicine. Then he went on to Vanderbilt for residency and University of Washington for Pulmonary Critical Care Fellowship, which is how I had the pleasure of first getting to know him as we shared a mentor in Dr. Christina Crothers. During his fellowship, Jerry established himself as a rising star in characterizing chronic lung disease for patients who are living with HIV, and also starting to quantify and characterize the impact of tuberculosis for long-term implications in lung disease for patients. In this light, he was awarded the Fogarty Global Health Research Fellowship and took the opportunity to examine the impact of TB, HIV, and cardiovascular and pulmonary events for patients in Kenya. This really marked the beginning of many of his accomplishments, awards, and honors, and establishing himself as a leader and a physician scientist in global pulmonary health. Tulane was able to recruit him back in 2019. And as you can imagine from, if you've ever spoken to him, he's been embedded in the residency program and really been a huge boost for, I'm sure, anybody that gets to work with him as a teacher as well as an investigator. He's established himself as a leader and was recently tapped to join the NIH guidelines for the Committee on Opportunistic Infections and Community-Acquired Pneumonia for people living with HIV through the Office of AIDS Research Advisory Council. He's joining us today and tomorrow to start to enlighten us about what he's learned for people living with post-tuberculosis lung disease. I'll also just say on a side note, Christina Crothers, like I said, has been my research mentor for 20 plus years and also is one of Jerry's mentors. And she was just so excited to hear that he was coming here and commenting on just what a tremendous person and an incredibly compassionate clinician and investigator and collaborator that Jerry has become. And I couldn't say it better than Christina's words. We're fortunate that Jerry visited us virtually several years ago, but really excited that we have him in person today and tomorrow. And want to just turn it over to Dr. Zifodya and welcome to Pulmonary Grand Rounds.
Thank you. Okay, thank you. Thank you very much. I am very excited to be here in person. As Kathleen was saying, I spoke to you all a couple of years ago during the pandemic, virtually, got a lot of great questions during that. So I'm excited to come back and give some feedback on some of the work that we've done since then. I have no financial disclosures. Okay, all right. So as I said, my talk today is on updates in post-tuberculosis lung disease, and I've termed it why we should care after quote unquote cure for TB. And hopefully I'll convince you that we should be thinking about post-TB lung disease and not just stopping at these people have completed their TB therapy. This is a brief outline of the things that I will talk about. We'll do a quick background, a brief history. We'll go on a little bit of a tangent on a brief history of tuberculosis, come back to mechanisms of post-TB lung disease, which I'll refer to as PTLD throughout the talk. Sometimes confusing. PTLD to me is post-TB lung disease. And then we'll talk a little bit about ongoing research. Okay. These are our three objectives for the talk today. Hopefully you'll be able to define post-TB lung disease after this talk and a little on its epidemiology, point out the gaps in TB care cascade, and then finally identify some subphenotypes as we start to think about post-TB lung disease. Okay, so a little bit on background. So TB is the leading infectious cause of death worldwide. It lost its throne recently due to COVID for a few years, but it is back, unfortunately, on top as being the leading infectious cause of death. And I am particularly interested in tuberculosis and people living with HIV. My initial research was in people living with HIV, and I think they give a great example, given the levels of immunosuppression, as to post-TB lung diseases, potential pathogenesis when looking at people with varying degrees of immunosuppression who have HIV. And as you know, there are increased risk for developing reactivation of tuberculosis and primary tuberculosis. Now, in the US, I talk about HIV and tuberculosis, and people are like, well, those don't really seem like problems here. Unfortunately, we are having a TB outbreak in the US right now, and we're seeing a lot more cases nationally. But what I will say is, yes, HIV/AIDS is at the top of the list for risk factors for active tuberculosis. But a lot of these other risk factors we do see, and these are some of the patients that I see in TB clinic here in the US, organ transplantation, chronic renal failure. In New Orleans, we see a lot of people with diabetes, unfortunately, alcohol use, smoking, all of these things. And then disease-modifying anti-rheumatic drugs. We see a lot of people who get referred to us for latent tuberculosis who are on these drugs. And the reason for that is they really increase your risk for active tuberculosis if you have latent TB. So as we have more and more of these therapies, TB is something that we need to also be thinking about here in the US, not just abroad. But when you do think about it as a international crisis, war and mass human migration have made TB make a comeback. It made a comeback during HIV. It's made a comeback now due to war and mass migration. Those are some of the reasons that we see it is overcrowding, malnutrition, suspension of healthcare services. If people were getting therapy for their HIV, they may not get that therapy for HIV again. So what I've highlighted, this is just Eurasia, and what you see is countries ranking in the top 20 for highest burden of cases, and countries in brown are highest burden of cases in addition to being highest burden per 100,000 people. And what you see here is Myanmar and then the Ukraine, which we know there's been wars there recently. We know there's been mass migration from there recently. And because of that, we've been seeing a lot of tuberculosis as well. No numbers from Gaza as yet, but I imagine we're going to see a lot of tuberculosis there as well, due to the factors that I've pointed out. Someone asked me earlier today when I was talking to the fellows if potentially one of the reasons for tuberculosis spread is climate change. Potentially, yes. Actually, there's a couple of very cool studies that came out of California where they looked at PM 2.5 exposure. And with PM 2.5 exposure events, there was an increased risk of TB transmission. And what they found was with wildfire events, there was more PM 2.5 exposure, but also there was more TB transmission. 23% increase in TB transmission during wildfire events in California. And unfortunately, we've had a lot of wildfire events in California very recently. So I think as we think about the US, I said it's a world problem as well, but as we think about the US, there's a lot of reasons potentially for some of these outbreaks that we are seeing with tuberculosis more recently. Now, we'll switch gears a little bit, and I will hopefully be able to make this clicker work. There we go. And we'll talk about post-TB lung disease, which is why we're here. So I've spoken about TB. And most of us worry about tuberculosis as just from the time of diagnosis, potential transmission to other people, to the time of quote unquote cure of tuberculosis. But there's an increasing body of evidence that points to individuals who are cured of their tuberculosis remain ill afterwards. So there was a consensus, a meeting in South Africa in 2019, just before the pandemic, and they sat down experts and looked at defining post-TB lung disease. And at the time, they gave it a very nebulous definition. It's evidence of chronic respiratory abnormality with or without symptoms attributable at least in part to previous TB. That's nebulous. What does that mean? It means if you have chronic respiratory symptoms, if you have abnormal lung function, if you have abnormal imaging after your tuberculosis is quote unquote cured, you have post-tuberculosis lung disease. One of the reasons they wanted to make it broad was they wanted people to start thinking about PTLD and post-TB lung disease more from a let's research this and look into this problem, because these individuals are increasing in numbers every single year. And one of the issues that we see with people with PTLD is they develop chronic respiratory symptoms, but not only that, they're at increased risk for subsequent infections, including recurrent tuberculosis. So these are people that we should be worrying about and thinking about. It's growing. This is just a quick PubMed little illustration. When I looked up post-TB lung disease very recently and just seeing the increasing number of publications. Now, from a pulmonary perspective, TB and post-TB lung disease involves several parts of your lungs. You can look at, it can involve the airways. So you can have TB-associated obstructive lung disease. That's where you'll see the low FEV1 to FVC ratios. You can have bronchiectasis. You can have parenchymal involvement, right? Cavitation, parenchymal destruction, fibrosis, aspergillus-related lung disease. These are people often who we'll see with, when I'll talk about spirometry later, restrictive type lung diseases. But then you also have pleural involvement, and you also have pulmonary vascular involvement, pulmonary hypertension, post-tuberculosis. So as we can see, it involves the lung from all the way on the outside in the, with the pleura all the way to the little airways. And so being cured and treated of your tuberculosis doesn't necessarily mean that your lungs are quote unquote normal after that and or you are cured. Now, I'm a pulmonologist, so I'm going to talk about post-TB lung disease, but that's not to say there's not other sequelae with tuberculosis. There's increasing bodies of evidence to show that there's morbidity in adolescents and children. Financially, if you have tuberculosis in a low and middle income country, it can be devastating from a financial standpoint. And then there's also the neurological disability and then the cardiovascular and pericardial disease. So there are several systems that are involved post-tuberculosis, but I am going to concentrate today on post-TB lung disease. But as I said, not to say there are not other systems involved. Okay, so how common is it? In 2023, 10.8 million people had incident tuberculosis. There were 1.25 million deaths. So that leaves you 9 odd million people who survived. And post-TB lung disease, we know, is in about half of people who survive tuberculosis. So that's potentially 4.77 million incident cases of new lung disease due to tuberculosis every single year. And to put it even more in perspective, there are estimated to be 155 million tuberculosis survivors in the world. So if half of those individuals have post-TB lung disease, it is a huge cause of lung function abnormalities and pulmonary disease burden in the world. So when you think about incident lung diseases such as COPD, such as IPF, we should be thinking about post-tuberculosis lung disease as well as a cause of lung disease. This is a meta-analysis that we've been working on, and we looked at post-TB lung disease manuscripts in low and middle income countries. And we wanted to, there's several meta-analyses that have come out recently that show that it's quite prevalent, right? But the questions were, are there different symptoms? Are there differences in what people are seeing in terms of lung function testing? So we looked at the different symptoms for the studies that reported these. And when it comes to cough, for instance, we had 19 studies, a lot of patients, and 33% of individuals who were cured of their tuberculosis-related ongoing cough, reported ongoing cough. When we looked at breathlessness or dyspnea, 47% of people had chronic dyspnea after their tuberculosis. When we looked at obstructive lung disease, just as an objective measure of abnormal lung function, we found that 25% in this group of studies had obstructive lung disease. And similar to other meta-analyses, restrictive lung disease was even more prevalent. There were 34% of individuals had restrictive lung disease post-tuberculosis in this group of studies in low and middle income countries. All this pointing towards a lot of lung function abnormality in addition to these individuals being symptomatic. A mixed pattern being obstruction and restriction, about 9% of people had abnormalities. So hopefully I'm convincing you that PTLD is, one, quite prevalent, and two, these individuals are symptomatic, so it matters. Now, anyone who's worked in tuberculosis has seen this before. This is the tuberculosis cascade of care. These are all the gaps that we think about as TB physicians, all the places where we miss patients and potentially lose some of our patients. It could be in the diagnosis, once being diagnosed, actually being registered in care, once being registered in care, actually completing your therapy, and once completing your therapy, actually surviving it. That's where we stop. I wonder if we need to add a next step, which is post-tuberculosis lung disease, something that we should be caring about and should be quantifying when it comes to individuals with tuberculosis. So, as I said, we'll take a little bit of a tangent here. Tuberculosis has been with us for as long as man has been documenting. So it's had several names. It was phthisis in Greece. So Hippocrates writes about phthisis, and it was one of the major causes of death there. If you look in Egyptian writings, and also they found it in mummies with Pott's disease, it's been with us since the Egyptian times as well. Thebes in Rome, Shashafeth in Hebrew. I hope I'm pronouncing that correctly. I probably am not. It shows up in Leviticus and Deuteronomy in the Torah or the Old Testament. Consumption, that was its name for an extended period of time. Captain of all these men of death is one of my personal favorites for tuberculosis. The White Plague and tuberculosis finally in 1834. So it's gone by several names, but it's been with us throughout history. So a little bit more fun history, hopefully for you all. Vampires in New England. So in the 1890s, there was a potentially undead scare in New England. And what happened was individuals would develop tuberculosis. And when you have TB, you become anemic, you become pale, and you develop hemoptysis. You start coughing up blood. So you have bloody sputum and you're coughing up blood. You lose weight over time, which is the consumption aspect, and you eventually die. Without therapy, that is. Unfortunately, it would be passed on to family members, and these family members would become anemic, would become pale, would lose weight, and would eventually die as well. So there was this fear that it was undead individuals who had died of TB who were coming back and feeding on their family members and therefore causing them to have consumption. So, in New England fashion, they exhumed some of these bodies. Some of them were buried with crosses on top of them. Some of them were exhumed and rearranged so that they wouldn't come back and feed on their family members, which potentially was spreading more tuberculosis. There was a big scare when it came to tuberculosis. Now, what does that have to do with vampires? Well, the original vampire story, which was written by Bram Stoker, was in 1897. He actually came to the US with a touring theater company a few years before. There was a story about a young lady, Mary Brown, who had died of tuberculosis, and the family exhumed the body, etc. And it's thought that Lucy, who's in Dracula, was inspired by Mary Brown. And Dracula is a fascinating read if you haven't read the original yet. But anyway, that is the potential history of tuberculosis and vampires. I shall digress a little bit more. When we think about the history, again, as I said, it's been with us for quite some time. But as we started to think about tuberculosis and phthisis more, this is from Joseph Coates. It was in the Glasgow Medical Journal in 1881. They were starting to think of it as having two potential phenotypes. There was one which was catarrhal inflammation, so coughing up pus. And coughing up thick mucus. But then they were also seeing a cirrhosis of the lungs, which is this potential fibrosis that we see with TB. So early on, when we were thinking about tuberculosis, we were already starting to see these potential subphenotypes of tuberculosis. Final tangent. John Hutchinson invented the first spirometer. I want to talk to you all a lot about spirometry today. It was an inverted calibrated bell, which he used for his spirometry, and he coined the term vital capacity because he could measure the amount of air that someone could fill their lungs up with and breathe all the way out, which is what we still do for spirometry. And that's the vital capacity. And the reason it's called vital capacity was if it was low, people would have premature mortality with it. So that's why he termed it vital capacity. Now, he carried out, this was his publication as it came out in 1846. He would have people breathe in all the way, breathe all the way out. If someone was deceased, he would go in, he'd put in what was in essence an endotracheal tube. He'd fill their lungs up with bellows, connect that to a spirometer, and then look to see what their lung function was afterwards. Now, why do I bring that up? Was because he found, I'll skip this slide and say he found an association with phthisis pulmonalis. As long as we've been measuring lung function, we've been seeing an effect of tuberculosis. And these are the people, he shows early stage and late stage tuberculosis, and he shows this decline in lung function when you develop tuberculosis. One interesting story was a gentleman called Freeman. He was a boxer from the US who went in 6'11", 434 cubic inches of air when he was healthy. And then after he developed tuberculosis, 344. So post-TB lung disease has been with us for an extended period of time. What also came out of this was what we have today, which is the taller you are, the bigger your lungs are. So that was fascinating out of this manuscript as well. It's a great read. Okay, all right. So I shall come back from my digression and let's talk about mechanisms of TB. Now, as I said, people living with HIV are helpful when we start to think about PTLD because a lot of us think it's somewhat autoimmune. It's not just the bacterium or the mycobacteria, it's actually autoimmune. So again, people living with HIV, they're at increased risk for TB infection. However, there's a lot of conflicting data as to whether or not they develop PTLD more. And I think there's various factors that contribute to this, including just the degree of immunosuppression when they started the antiretroviral therapy as this TB iris, and also microbiological and host factors. There's interesting finding, which is an HIV paradox in post-TB lung disease, which is those individuals who are more immunosuppressed have low CD4 cell counts when they're diagnosed with their TB are much less likely to develop post-tuberculosis lung disease. Whereas if you have HIV, you're well controlled, you're on therapy, you're more likely to develop post-TB lung disease. So I think that's the clue towards the cells that are taking part and causing this post-TB lung disease. This is the LIFT iris cohort out of South Africa, and they showed TB iris to be associated with post-TB lung disease. And what they showed was they did PET scans before and after starting antiretroviral therapy. And as you can see, once you start antiretroviral therapy, these are people who had iris, but interestingly, you had a lot more inflammation after starting antiretroviral therapy. They showed that these individuals also then had a lot more abnormal lung function. So maybe your CD4 cells coming in play a role in this autoimmune dysfunction, which is post-TB lung disease. In addition, TB causes parenchymal destruction, but I think it is a dysregulated inflammatory response. A lot of us think that, and if it persists, it could potentially lead to chronic lung disease. Matrix metalloproteases are something that we think about a lot as well. When it comes to pulmonary fibrosis, I think one of the problems we've had is we've lumped post-TB lung disease together. Are there different potentially subphenotypes? And are MMPs leading to PTLD, but a specific type? That's one of our questions as well. This is part of my conceptual framework when we think about it, which is, yes, tuberculosis leads to, there's type 1 interferon signaling after TB. That's great early on. It helps with your suppression of the bug. But if it persists, that's bad because it causes autoinflammation. And then there's also other pathways which cause inflammation and immune activation. HIV is an interesting confounder here, right? Because again, you're at increased risk for TB, but as I said, if you have HIV, potentially it can, if you're immunosuppressed, it could potentially reduce this inflammation and signaling. However, type 1 interferon signaling is dysregulated if you have poorly controlled HIV. So it serves as a confounder, which is very interesting in terms of what do we do or how do we think about people living with HIV. And then finally, this inflammation, immune activation potentially lead to this post-TB lung disease. I've said all those things already. Now, this was, I'm on a K23 right now. When we wrote the proposal, this was one of the images we put in there. And the way I think about post-tuberculosis lung disease. So you have Mycobacterium tuberculosis, phagocytosis is the macrophages. These signal with type 1 interferon, TNF, IL-1 beta, matrix metalloproteases, potentially leading to lung damage, right? But then also, right, you have antigen presentation with these macrophages to your CD4 cells. These can also then produce your interferon gamma TGF beta, potentially leading to lung dysfunction and or lung damage. Now, we spoke about HIV. You would potentially have fewer CD4 cells, potentially less of this interferon gamma TGF beta signaling, and potentially that's why people who are immunosuppressed have less PTLD. So that's one of the thoughts when it comes to mechanisms. This is out of a very interesting review that Sarah Auld and the team at Emory and the people who were at the last post-TB lung disease conference came up with. And it was thoughts as to what are all the systems that are involved in post-tuberculosis lung disease. I won't belabor them, only to say extracellular matrix destruction is one of the things that we think about. The MMPs, as we spoke about, which cause extracellular matrix destruction, neutrophils, cell death, granulomas. But then there's also these clinical risk factors that we think about as well. And then also just the MTB in itself. Okay? All right, so there's a lot of gaps in knowledge. A lot of the studies that we look at that talk about post-TB lung disease are remote from when people had their tuberculosis. There's few prospective studies, although that's growing and that's changing over time. And then we don't really know the temporal progression very well and or what are the risk factors for post-TB lung disease. That leads us then into what were the research priorities that were outlined by a network of experts, and it was, let's describe the severity and the phenotypic outcomes of post-TB lung disease. Let's further elucidate the mechanisms of damage. And then also, one of the things that's important, which is a patient-centered outcome, is recognizing that have heightened risk for infections, including recurrent tuberculosis. So this brings us to my ongoing research now. This is on my K. I'm mostly going to talk to you about my specific M2, which is determining transcriptomic responses in activated PBMCs that can predict impaired pulmonary function. Okay. So I presented half of this to you before. However, again, tuberculosis in itself can cause direct parenchymal damage. If you have a high bacillary burden, detectable TB post-treatment, all those things can potentially lead you to PTLD. One of the things I'll talk about tomorrow is female sex as a confounder as well, because we're finding some sex differences in post-tuberculosis lung disease. A little bit more exploratory. Okay, so we've enrolled in Nairobi. That's where I'm doing, that's where we have a cohort right now. And what we do is we enroll people at the time of TB diagnosis prior to therapy. We draw blood. So the PBMCs that, and some of the data I'll be talking about is pre-treatment PBMCs. And then we draw blood again at month 6, which is treatment completion. We've also done spirometry, and this is the results of the spirometry. Normal is in dark blue here. Light blue would be restrictive impairment, a low FVC. We can't fully call it restriction, but a low FVC. Light green would be obstruction alone, and then dark green would be obstruction and restriction. And so this is spirometry in this cohort of individuals at month 6, 12, 18, and 24. And note that at any one of those time points, when we're looking at lung function, half of the individuals have abnormal lung function. Initially, restriction predominates, but as you go further out, you start to see more people who have obstructive impairment. Now, the group I want to talk to you about is these people at month 12. These people we've defined pretty well now. And there are 205 of them with acceptable spirometry, but only half of them have normal lung function. Now, what's important here is people will say, well, yes, they have abnormal lung function. They live in Kenya, though. Potentially they smoke, socioeconomic status, et cetera. Are those things leading to their abnormal lung function? Yes, potentially they are. However, we've enrolled household contacts, 34 of them with spirograms, 33 with acceptable. And of those 33 people, this is a growing number of people now, only 5 of them have abnormal lung function, as compared to half of the individuals who've had tuberculosis. So I think we can pretty safely say it seems to be the TB that's causing the lung disease, even when we control for exposures at home. Now, as I said, I'm concentrating on the month 12 visit. This is 6 months after treatment completion that we are looking at these individuals. We had 222, 205 of them have acceptable spirometry, so 92%. That's about par for the course with these studies. And my question is, are there baseline characteristics that predict post-TB lung disease? So this is our basic patient characteristics. In this column, I have the PTLD, post-TB lung disease, and this is normal lung function. And in terms of clinical characteristics that we start to see, BMI seems to be higher in those with normal lung function than those with PTLD. MUAC is mid-upper arm circumference, which is a marker of malnutrition. That seems to be strongly associated, although not that big of a difference, however, strongly associated. So the more malnourished you are, the more likely it seems you are to develop post-TB lung disease. Prior tuberculosis, this is not novel. Other people have shown it. If you've had prior TB, you had increased risk for post-TB lung disease. So 30% of our PTLD cohort, 27%, as compared to just 11% in the normal lung function. And then this time to culture conversion as well. So if you have a higher bacillary burden, again, that's not novel. If you have a higher bacillary burden, right, it seems you're at increased risk. Now, one of the things that I think is important to always look at is the patients as well. And importantly, the second half of the table is when we bring them back at 12 months, are they still having symptoms? And yes, they are. As compared to people with normal lung function, 30% report cough, and 20% as compared to 10% report ongoing dyspnea. So these are people who remain symptomatic after TB, and half of them have abnormal lung function. So then the question is, what are the determinants, clinical risk factors for developing post-TB lung disease? So we initially looked at it as a group, which is anyone who has abnormal lung function compared to anyone who has normal lung function. Cavitary lung disease, a risk factor, not novel, makes sense, right? This mid-upper arm circumference, again, stands up as a predictor. Oh, I should say these are unpublished data. We're working to submit this pretty soon, so please don't share. Please don't share. Mid-upper arm circumference still stands up, right? So this malnutrition potentially has a marker of potentially developing eventual post-TB lung disease. Prior tuberculosis and the number of chest X-ray quadrants that are involved, I didn't show it, but it's 2 chest X-ray quadrants as compared to 1 in people with PTLD compared to people with normal lung function. Okay, those make sense. But I think one of the problems, again, is we've been grouping this, and I think that's part of why we don't have a good indicator of clinical risk factors. So what we then did was we took restriction alone, so that low FVC, and then we took obstruction alone, and we looked at what are the clinical risk factors for those. And when you look at restriction, you have cavitary lung disease, mid-upper arm circumference, number of chest X-ray quadrants that are involved. That's what we're seeing as risk factors. Now, when you look at obstruction, interestingly, that prior TB, which for some reason doesn't look to be a risk factor in restriction, is the risk factor in obstruction. Why? I don't know, but that's a clinical indicator that looks different there. In addition, it's the chest X-ray quadrants. Cavitary lung disease doesn't seem to play as big of a role in obstruction as it does in restriction, which again, clinically makes sense, right? The prior tuberculosis we shall figure out, but it's quite a strong signal here with obstruction, whereas when it was with restriction, really not that much of a signal at all. So different clinical risk factors for obstruction versus restriction when you start to subphenotype them. This mid-upper arm circumference I've been talking about a lot, and what you notice is it is very different in people who develop restriction as compared to people. This is normal lung function in gray. Restriction is in blue, very low. In obstruction, it is lower than people with normal lung function, but a little bit higher than it would be in restriction, although not statistically significant. So this mid-upper arm circumference is one of the indicators that's novel that we're finding. It correlates also with our BMI, but it seems to be a stronger indicator than the BMI. Other indicators are, CRP has been one that's been brought up as a potential indicator, and we didn't see a signal for it when we grouped the people as post-TB lung disease versus not. However, when you look at people with obstruction alone, as compared to people with restriction alone, you see there's no difference between them and normal lung function. However, it looks like obstruction, and we see this in the data, people who eventually develop obstruction have a lower CRP compared to people with normal lung function, and it's definitely statistically lower than people who develop restriction. So it seems there's this high CRP in people who develop restriction early on. The CRP is measured at the time of TB diagnosis, and it's higher in those people who go on to develop restrictive lung disease. We looked at cough peak flow. This one is intuitive, which is people who go on to develop obstruction have a lower cough peak flow than those who develop restriction. But that's another potential clinical indicator that's easy to measure early on as to can we differentiate who's going to develop what. And then we did RNA sequencing. I'll spend a little bit of time on this. This is just to show that the clinical characteristics of the subset of people who we have RNA sequencing on are very similar to those who we don't. It's only 75 individuals who have RNA sequencing. I'm nested in an R01. I have limited funding, but we do have 75 people with RNA-seq. Okay, so this is month 0 RNA sequencing. So this is the blood that we drew from them prior to therapy. For those who aren't familiar, this is a volcano plot. What you'll see is genes that are potentially upregulated over here, downregulated over here, and then for significance, it's further up in terms of the log 10p. So what we don't see is a lot of genes here. This is just with the p-value of less than 0.5. And when we looked at it in terms of pathway analysis, this is pathway analysis on the right, for those not familiar. We saw some signal for KRAS, apical junction complement, but not very convincing. And we had no differentially expressed genes with an FDR less than 0.2. So this is anyone with PTLD versus not. This is restrictive impairment versus normal lung function. And what you see now is when you subphenotype your post-TB lung disease into restrictive impairment, not just PTLD, you see these differentially expressed genes. We have 140 something of them. MMP being a very interesting one because MMP is associated with restrictive lung function and matrix destruction, right? And then these pathways, IL-6 JAK-STAT, TNF-alpha, these are the pathways that, I'm at Yale, there's a lot of ILD researchers here. These are the pathways that we start to think about as well when it comes to interstitial lung disease. So this makes sense, which is at month 0, the people who develop restrictions seem to have immune activation, inflammation that's causing this lung damage. And I showed earlier that their CRP at baseline is higher than people who develop obstructive impairment later on. So potentially arguing that this is a very, very different PTLD than what we're seeing with obstruction. What makes this even more compelling is that when you look at obstruction versus normal, this was that 40-some patients who developed obstruction versus normal, you see nothing. We had no differentially expressed genes as compared to 140 something, and you don't see really any pathways that light up. So again, this argues that potentially these subphenotypes are not only subphenotypes, they have endotypes that are different as well. And that's what we're seeing in terms of this post-tuberculosis lung disease. Now, what I'm even more excited about is that we have some month 6 data. This isn't a smaller group of individuals, 30-some individuals. It will eventually grow, but again, funding limitations as a K-funded researcher. I showed you earlier that in our conceptual framework, when we were thinking about it, we thought people who develop PTLD potentially have persistent interferon alpha signaling or type 1 interferon signaling. We showed that at month 6, they do have type 1 interferon signaling that's activated. In terms of when you looked at DEGs or differentially expressed genes, there weren't that many. One thing that was interesting here, though, is EXIST. This is X chromosome inactivation. So that made us go down the pathway of sex differences, which I'll show a little bit of tomorrow, but that is an interesting finding there as well. But type 1 interferon signaling, when it's PTLD versus not. But again, as I said, let's subphenotype it and think about it. When you look at restrictive impairment now at month 6, restrictive versus normal, you don't really have that many differences in restrictive versus normal, particularly when you look at the gene set enrichment. I'm oversimplifying it, but when you look at gene set enrichment, you don't really have that much difference. This is at month 6. These are people who are cured of their TB. It seems there's not that much difference when it's restrictive impairment. So maybe they took their hit early. Obstruction versus normal at month 6. We see a lot of changes. We see a lot of difference. We had 340 something differentially expressed genes. This is at month 6, which is treatment completion. These are people who are cured of their tuberculosis, and yet we're seeing this immune activation, this inflammation, and all these pathways, including type 1 interferon, interferon gamma, which you shouldn't be seeing post-treatment, IL-6 JAK-STAT, TNF-alpha, et cetera. We're still exploring some of these, but it's quite a different endotype when you think about restriction versus obstruction, which seems restriction is that early damage, but obstruction seems to be that later damage. And to support this, there's been manuscripts that show post-tuberculosis, even after treatment completion, some people go on to develop progressive obstruction, and there's this gradual decline in their lung function. We're seeing it as well, and I showed you that there's more predominance of obstruction later on. So is it that obstruction is this ongoing inflammatory milieu that's potentially leading to this obstructive impairment? potentially. That's the argument that we're making. And for fun, make this a dark room and show you that these are the individuals that we're seeing. I said it's symptoms, it's spirometry, and it's imaging. This is our pre-treatment chest x-rays. We have sick patients with bad tuberculosis. So these are some of our pre-treatment chest x-rays. What is interesting though is these are some of our people with post-treatment chest x-rays. And you can see here volume loss, tracheal deviation, you're developing this fibrotic lung disease. This person, if I saw in clinic, I would say this person looks like they have tuberculosis, and more so this individual who is post-treatment. If they came to me, I would be very concerned for TB as well in Kenya. So we've come full circle. We're almost at 15 minutes for questions. I've talked about the background, a brief history, mechanisms, and ongoing research. What I haven't spoken about is treatment. That's because there's really none. So unfortunately, there's not that much. There was this manuscript that came out, which was clinical standards for assessment and management. And all they really said was, let's look for it. Let's consider pulmonary rehabilitation. That was an IJTLD 3 years ago when people were starting to think about PTLD. There are recommendations as to things that we should and could be measuring, particularly in a research setting, be it spirometry, chest radiography, CT scans, considering DLCO, CPET, 6-minute walk test. This is pie in the sky stuff. What I think most people agree on is let's check for symptoms and let's do chest x-rays post-treatment and look for these people who potentially have PTLD. In terms of spirometry, that's a little bit harder to implement. We just started a study in Mozambique looking at implementing spirometry in a rural setting. There's a few other studies that are doing it as well. It's harder to implement in a rural setting. And the question then becomes, okay, fine, you diagnose them with post-TB lung disease, but how are you going to treat them? And really, honestly, we don't know. There's currently very few guidelines. If it's bronchiectasis, now what I've started doing in my TB clinic in New Orleans, we're going to potentially be referring to a non-CF bronchiectasis clinic. If it's obstruction, some people are just treating with inhalers, so bronchodilators. And then if it's restrictive, really just pulmonary rehabilitation. But there's not much so far. The other thing that I would say is these individuals will probably benefit from vaccinations. They have structural lung disease. We should be vaccinating them for things like influenza, pneumococcal vaccinations, Tdap, and then also encouraging smoking cessation if these individuals smoke. So these are some of the things that we think about when it comes to therapy. It's depressing to say all of this about treatment after telling you all I'm very excited about potentially figuring out who develops PTLD. But one of the thoughts is, can we eventually have host-directed therapy so that we avoid this post-tuberculosis lung disease? And one of the ways of having host-directed therapy is figuring out who is going to develop PTLD. So that, I think, hopefully is one of the frontiers that we're yet to figure out, but hopefully one of the ones that will conquer very soon. And then we need to integrate TB care, international TB programs, post-TB care, because these people are cured, they go out into the world and we let them be, but they're sick. And they have symptoms and they have lung disease. So in terms of a quick discussion and then open for questions, there are distinct pathways. Hopefully I've shown you that restrictive impairment and obstruction have different clinical risk factors in addition to having different endotypes. There's very currently few treatment options, but these distinct immunological endotypes, I think they're exciting, right? It's a promising avenue for potentially host-directed therapies. And my future directions would be validate these data, adding diffusion capacity is something that we're doing very soon. We have CT scans. I'm going to show some of those tomorrow. And then we're also looking at longitudinal analyses of these potential people whose lung function is getting worse over time. And then we need funding towards larger multi-site cohorts. I'll leave it at that. Okay, these are my acknowledgements.
All right. Thank you so much, Jerry, for this really inspiring talk, and really appreciate your international experience on this as well. I'm going to start with one of our Zoom questions and then open it up for people in the FitKin as well. So we have a question from someone saying that in their TB screening program in prisons, we saw a fair proportion of chest x-rays suggestive of COPD at baseline TB diagnosis. This person's wondering about the impact of previous or underlying lung disease that may impact post-TB lung disease, and whether we assess for, or you assess for previous lung disease beyond prior TB in your cohort.
Yeah, that's a great question. We do ask that question. I think that's going to be more relevant in a US setting sometimes, because we ask, have you had asthma? Have you been diagnosed with COPD? Almost invariably, everyone says no. There's very few people who will say yes, potentially to the asthma, but the COPD, almost everyone says no, because we're not diagnosing COPD, unfortunately, in low income settings to a certain extent. So the answer is yes, we ask those questions, but very few people say yes. And one of the ways we've tried to control for this now is, okay, let's have people with similar exposures, which is that control group, and see if they have abnormal lung function as well. But that's not a perfect answer. That's actually one of the big limitations, right? Is all of this post-TB work is in people who you catch post-TB. Right now, we're, at least starting with them at the time of TB diagnosis, but you don't really fully know what their lung function was like beforehand. But hopefully showing that family members who live in the same homes or have the same exposures have much less lung disease points to the TB.
Thank you. I guess another question I had about the exposures is the tobacco access and use, and how that might also lead to differential effects for long-term lung damage.
Yeah, great question. So in terms of tobacco use, we actually had a lot of people who reported some current or former use of tobacco. I think part of that is because we're working in Nairobi, which is more urban. In my previous work, we had worked in Kisumu, there was almost none, but that's a more rural setting. Do I think that contributes? Absolutely. Which is, I think we should argue for, if someone's diagnosed with PTLD, similar to if someone's diagnosed with COPD, counseling them on tobacco cessation, because I think it does play a role in potentially their abnormal lung function. Now, have we looked at this more in depth? Not as yet, because it's very difficult to, the people who report smoking, it seems to not be that extensive in Nairobi. Again, we have 40 people who report current or prior, 40% of people who report current or prior. But when you look at the number of packs per day or the number of cigarettes per day, it's not that much. So I think, again, it'll make a big difference in areas where we have a lot of smoking. Like PTLD is a big issue, for instance, in China. There's a lot of smoking there as well. Potentially, is it going to play a bigger role there? Tobacco use, absolutely. We looked at it in this cohort. We adjusted for it. It doesn't seem to make a big difference, except for lower FEV1 to FVC ratios in people who smoked.
All right.
Thank you for an excellent talk. I'm wondering, to what extent do you think the post-TB lung disease, to what extent can you learn from other diseases that follow a progression of healing versus destruction? And to what extent is TB separate? So for example, we see patients with bacterial pneumonia who some end up with no evidence that they ever had pneumonia, others with scarring and even permanent lung damage. See the same thing with ARDS. I know that the people in here who study interstitial lung disease know that some people with hypersensitivity pneumonitis might do very well with steroids and getting away from their exposure, and others progress to a fibrotic disorder. So are there themes that have been developed in other diseases where patients follow a different time course that might shed light on what you're trying to unpack in TB?
Yeah, that's such a great question. And it's one that we've been asking ourselves as well, as should I be talking to and thinking about, well, yes, I should be. Looking at people who do long COVID work, for instance, because that's one of the ones that we see. When we did the study in Kisumu, we looked at not only tuberculosis, we looked at any prior pulmonary infections. And prior pulmonary infections were associated with abnormal lung function. But the strongest signal was with tuberculosis. However, yes, there are other diseases that we can learn from. I think you asked, how is TB unique, though? I do think it's unique because by the time you get diagnosed, right, it grows so slowly. You've been exposed to its antigen for an extended period of time before you ever become symptomatic enough to be diagnosed with it, which, if we're saying this is inflammatory and autoimmune, if you've had that antigen lying around for the last 6 months, 1 year before you get diagnosed, potentially you've had some of that damage happen already, like the people with restrictive impairment that we're showing. In addition, it's such a long time course for treatment. Bacterial pneumonia, I'll give you 5-7 days of antibiotics. You walk out, you're fine. TB, we're going to treat for the next 6 months, maybe 4 months. And during that time, you still potentially have persistent antigen. There's a great work from Anna O'Gara's group. She does TB work, and they showed persistent antigen even after treatment or cure. So is that those obstructive impairment people who were seeing inflammation and immune activation from? Potentially, yes. It's so hard to treat. It's so hard to diagnose, and it sits with you for such a long time that I think potentially it has more time to cause damage. But I don't think it's unique and alone in causing lung disease as it comes to pulmonary infections. So one of the goals, as I was talking to Jake Hall's one of my mentors recently, is potentially reaching out to people who are doing some of the work with long COVID and other infections as to what are they seeing, and are there other questions that we need to be asking? That's a great question. I don't think it's completely unique.
All right, hand it over to Sebastian.
Hi, thanks again. We had a lot of good discussions during our one-to-one meeting. There was one thing I just got struck by the chest X-rays you were showing.
Yeah.
Each individual had upper lobe disease, which is a classical post-primary TB, what we see. It's hard to think that this local upper lobe process is going to lead to an obstructive phenotype like post-obstructive lung disease, unless you think about somehow inflammation must essentially drop down, right? So any thoughts on if you have this upper lobe infection, could it actually be endobronchial spread down into the lower parts of the lung to cause this more diffuse phenomenon in probably small and larger airways to cause this obstruction? And the second comment on that, you mentioned that reinfection is actually a risk factor for obstructive lung disease, which also begs a question about antigen persistence. Did they really clear their infection?
Yeah.
Or is it a smoldering, ongoing infection, or at least antigen persistence that leads to that phenotype? By the way, as a side note, I think that's bad news for people who want to come up with a vaccine, right?
Yeah.
If your primary infection is not protecting.
That's a fantastic question. I also, I'll say, first of all, I was surprised by the upper lobe predominance, because we always get taught, in the US and in high-income countries, it's reactivation tuberculosis. In low-income countries, it's primary tuberculosis. We have a lot of these upper lobe predominant, what we would typically think of as reactivation tuberculosis. I was first of all surprised that it's mostly upper lobe predominant in our chest X-rays. I'll say that it could potentially be reinfection. Yeah. 100% agree. I was just surprised. I thought I'd see a lot more diffuse TB because it's primary. What we're taught in med school is, right, it's meant to just look like bacterial pneumonia, not like TB when you're getting primary TB. I think the localization that's just the most involved area. That's what we're seeing on the chest radiograph. But do I think that's the only place that's got tuberculosis in your lung? I don't think so. I think you're seeing antigen throughout, and that potentially will explain this potentially eventual obstructive lung disease. You and I spoke about it a little bit earlier. Some of these people end up with air trapping as well. And there's that small airways disease from this TB antigen, potentially, absolutely. And that would potentially explain some of this obstructive lung disease as well. I think what we see on chest radiograph is just an indicator of this is the worst place that's involved by tuberculosis, but really it's throughout the lungs by the time we're seeing it, and they're seeing antigen. To answer your question. So I think that's definitely what's going on. And then reinfection, is it reinfection? Or is it just TB that didn't go away, sat with you for years, and then just decided to come back up? I don't know.
All right. Dr. Davis has a question for you.
Jerry, fantastic talk. You mentioned extrapulmonary manifestations of TB. And my question, because I know you've worked, I think Kathleen mentioned you've worked on cardiovascular complications. The high rates of dyspnea is sort of out of proportion to the lung function abnormalities and the cough. Do you think this is a general process like other chronic lung diseases that are affecting respiratory muscle, not just respiratory muscle function, but other kind of elements that contribute to dyspnea besides just lung function?
I think so, Luke. I very much think so. And then one thing we've not looked at all is, yes, they have all this dyspnea. Not all the dyspnea is pulmonary, right? As we spoke about the cardiovascular dysfunction, a lot of people develop pulmonary hypertension. There's this pericardial involvement and inflammation that we see with tuberculosis as well. We are subphenotyping just the lungs, but the heart has issues as well during and after tuberculosis treatment. So could some of this dyspnea be due to that as well? Yes, there are excitingly, studies now being done with echocardiography post-tuberculosis. I'm excited to see what the results of those show. There's a couple of groups that are going to be doing that work, but we unfortunately haven't done that. So I think it's not just dyspnea from the obstruction or the restriction alone. I think there's other processes involved in people, which is why it's out of proportion and why so many people with post-TB disease have dyspnea, which one of the arguments and the questions is, should we just define it by spirometry? Or should we define it by virtue of the symptoms? Because these are symptomatic people. They may not have, some of them may not have abnormal lung function, but they're still really short of breath, potentially. I don't know the answer. Well, yes, I think so, is my answer to that.
And Jerry, we do have a few more questions, but also Dr. Mathey had asked on the chat about the impact of HIV and AIDS.
Dr. Mehta, I hope you're at the research conference tomorrow. We'll talk about HIV a little bit. I did not talk about it today. I don't know why I'm yelling because you can hear me fine on the microphone. Sorry. There's one study that came out recently in IJTLD that looked at HIV. A lot of the studies with HIV and PTLD looked at HIV and imaging and PET CT scans, but not lung function afterwards. For those who won't be there tomorrow, show a linear relationship. It's fewer people living with HIV. It's only 10% of our cohort. But the higher your CD4 cell count, the lower your FVC. So we do show this linear relationship with better better control of your HIV, higher CD4 cells, worse restrictive impairment, which again lends to this CD4 cell mediated inflammation, immune activation, and abnormal lung function. So I think HIV is very instructive when it comes to PTLD because it very much lends to the argument that it's not just the mycobacteria, it's actually very much autoimmune as well, or an aberrant immune response.
That's great. I invite others to come down and speak with Jerry after his talk. And thank you again for all of your wisdom and sharing with us today.
Thank you.